Good morning, and welcome to today's discussion on collaborating across systems for system change. Today we are joined by Dr. Allison Ancher, Prince William Health District Director, Becky Sutter, Mason and Partners, MAP Clinic Co-Director, and Major Mandy Lambert, Director of Support Services, Prince William Manassas Adult Detention Center, and President of the American Jail Association. The three of them will share how they worked together across health and criminal justice systems to help people with substance and opioid use disorders in Northern Virginia and help them get the care they need. The Northern Virginia Health Foundation has funded this and other collaboratives because we are focused on systems change. It is clear to us that meaningful systems change requires the serious involvement of multiple sectors, and this is an excellent example of that. So with that, I would like to open the discussion. If you have any questions for our guests, you can submit them via the Q&A box at the bottom of this window. We will be taking questions after today's presentation. Now I'd like to turn to the first speaker. Becky, I'd like to begin with you. Can you tell us briefly about the collaborative and the work you are doing?
Sure. First of all, Pat, I want to thank you for inviting us here today to talk about this important collaboration. This work that the foundation has supported has been some of the most impactful change I have seen in my career. About 60% of state and federal prisoners have substance use disorder, in many cases, opioid use disorder. Unfortunately, opioid use disorder typically goes untreated during incarceration, which puts inmates at high risk for reoccurrence once released. This can also, unfortunately, lead to what we call a lost opioid tolerance, which can result in overdose should they have that reoccurrence. Research suggests that formerly incarcerated people have a nearly 12-fold higher mortality rate during the 2 weeks following release from incarceration than the general population. And fatal overdoses certainly lead to that statistic. We simply must prioritize making medication for opioid use disorder more widely available. Dr. Ancher, I, and Major Lambert have been working together for many years, most notably through our work with the Prince William Evidence-Based Decision-Making Team. We've been doing work integrating peer recovery specialists into the Manassas Adult Detention Center and with other criminal justice partners in the Prince William area for a few years. This work had us looking at how we could identify high-risk, high-need individuals with opioid use disorder and get them quickly navigated to appropriate community-based services. While we had great success with that collaboration, it was obvious that there had to be a quicker access point for services, most notable access to Suboxone. That's where the collaboration and support from North Virginia Health Foundation came in. We believed from the beginning that the changes that were needed were not just changes that we could do within our own areas and with our own individual processes, but it needed to be done in coordination and at a system level. We needed to work together on a solution. Because of the existing collaborations that we had, we already had the built trust and developed strong working relationships. I believe that had been key to the success of this program as well. We worked strategically with the ADC to look at where there were interventions on early identification through universal brief screenings and other areas where we could potentially identify and bridge using our peer recovery specialists. They had been core to the success of our previous work, and we knew they needed to be part of this work as well. We needed to bridge those needing high touch navigation to a low barrier, quick access solution to getting the medication that they needed. You know, every time I talk about this program, it sounds simple and obvious, but the work took time and real learning of each other's language, exploring what was possible in each of our individual systems and how to not only integrate and combine our own resources, but also to ensure that other community partners could also be connected to the work. You know, we've created an amazing process where there's shared information, quick access to services, continuity of care. We not only bridge into the community from jail, but we have over the past year developed a bridge into jail should one of our community-based clients become reincarcerated. That creates a seamless system of care. We've done system level change from leadership teams to frontline staff, and we've developed collaboratively the process and the culture that is needed to have our MAT clinic work and to have anchors in both the jail and the community.
Thanks, Becky. Dr. Anscher, why is what you're doing important for public health? And what other resources, if any, have resulted because of this work?
Well, as Dr. Sutter or Becky had mentioned, we were seeing an increase in overdoses in the community. And in fact, the folks that were coming over for care to the health department from the adult detention center were people that we would not have expected to be seeing. They were professionals who were incarcerated for some association with substance use disorder. We were also seeing an increase in babies being born addicted. And many of these women may have been incarcerated and coming to the health district for care. It became clear to us that there was not enough services for those who are uninsured or even Medicaid with substance use disorder. We also had to change the mentality of the community as well as of our own staff as to the causes of substance use disorder, that it's a chronic condition, that people need ongoing care, and they need these wraparound services to make them successful. What we did then, we really rallied the community in our community health improvement planning to understand what substance use disorder is. And we did many community town hall meetings, et cetera, to change the opinion of how people viewed substance use disorder. This allowed us, I believe, to help us be successful as we collaborated, the health district collaborated with George Mason and the Adult Detention Center to allow these changes to be acceptable and to occur. Changing the mentality as to what substance abuse disorder is. It's important because we know that incarceration has been used in the past to address our longstanding war on drug use, and it's not the right way to address substance use disorder. We're lucky that our adult detention center is very compassionate and was willing to work with us on allowing the peers in, allowing medication-assisted therapy to be continued in the adult detention center, as opposed to having our inmates who came in on medication-assisted therapy to have to detox, go out, start using what they used before they entered the entered the ADC, go out and then overdose because they are using the same amount they did when they entered. So we're very fortunate through that evidence-based decision-making. As Dr. Sutter mentioned, we built trust and prevented those silos from inhibiting us from making a successful program.
And as a result, what resources have you identified?
We were able to get a federal grant through the Virginia Department of Health that has continued to fund this program, and it allowed it to grow, which is important because it also allowed us to have other resources from the Virginia Department of Health to support this, as well as provide other communities ways to address this issue in their community. Our community initially was not as open to understanding how to treat substance use disorders. And I believe this program has also helped to change the opinions of our community members to support us and to understand it has also allowed us to help the community to perhaps progress into other support systems for substance use disorder. So we continue to look for additional grants, whether they're federal or local. But the ECOP grant through the federal government has been significantly helpful.
Thank you. Major Lambert, what were some of the obstacles you encountered along the way? What did it take to change the culture in the detention center? And how did you address stigma reduction?
So that was probably the biggest challenge for our environment, was accepting of peers coming into our facility. We introduced them through education about SUD and what that looked like. So the staff here were educated. We utilized Dr. Sutter, Dr. Ansher to help us facilitate some of those education pieces that were necessary. For our staff here at the detention center to really kind of understand what substance use was. Once we felt that they had accepted substance use disorder as a disease, we were able to talk about medications that we ordinarily would not have people removed from, such as insulin. So we were able to use some of the types of medical conditions that we regularly see come into the detention center and model SUD after those chronic conditions that we typically see here. The introduction of peers was probably the heaviest lift. Peers coming into a jail setting in an environment such as ours, having previously been incarcerated, is unheard of. That is something that culturally in a jail setting, we don't permit. Do we allow former folks that have been incarcerated to come in and do AA or NA? Yeah, we do. However, peers took on a much larger role. They were in our booking area, they were interviewing inmates, they had some level of free roam within the facility, and staff were resistant, very resistant. So what we did is I would be here at midnight, 3 o'clock in the morning, helping the peer navigate and introducing the peer to the staff that they would be engaging with. As with anything, pattern of the continuation of coming into the facility tended to be just readily accepted after a while. And I think in my lens that you really do have to have somebody that has policy level decision making, that has bought into the concept, that is a champion and truly understand substance use disorder, making the pitch. Jail folks are tough folks to break down. We are very set in our ways. And that, in my opinion, Pat, was probably the most challenging. Breaking down silos was probably the second most challenging. You know, when you listen to Dr. Sutter and Dr. Ansher talk, they're talking very clinical. We don't have that background. We see it day in, day out, and we see the tragedies that occur in families' lives, and we see the destruction that substance use causes. But unfortunately, our go-to is, well, they should have never done it in the first place. And we had to get past that. So in our steering committees, which were developed early on, which was probably one of the the best thing that we did, was having the right people at the table to talk about how do we bridge that, right? So the steering committee helped us focus on the resistors, helped us focus on the education piece, helped us really kind of outline actionable items and figure out ways to measure outcomes of success. When we were able to pitch it that way, the buy-in happened. It just happened. It wasn't It wasn't because it wasn't a lot of work. It was a lot of work. There was a lot of frustration. There was a lot of one-on-one conversations with me and staff. But it wasn't in a disciplinarian way. It was consider thinking about this as a family member, right? And what we learned very quickly is many of us that works in the industry knew someone that had an SUD, whether it was a family member or a friend. So being able to tie that to what we were trying to achieve and doing the right thing, it probably took about a year to really get to where everybody was, it was just kind of a normal everyday occurrence, administering what we refer to as our PNR, which is identification of those that suffer from SUD early on when they walk through the door, we know, and then addressing the MAT, and then, making sure that there were connections to resources after the fact. So I would say that the biggest challenge in our setting, in a jail setting, for those jail folks that may be on the call, is the buy-in from staff. There was a lot of resistance, but if not for Dr. Sutter and Dr. Ansher, I would not have been able to do it on my own. I did not have the clinical background. So for them educating me so I could educate myself, my staff, was the key for the buy-in.
So let me focus on this issue of systems change, because Major Lambert, you just gave several examples of changes in your system. Becky and Allison, what changes in systems have you encountered as a result of this work?
So for us, George Mason University is an academic institution. And so every work that we do, both is direct provision of care and looking at where we can fill gaps, changing models so that we can really work together. But, one of the largest system changes that I can do as an academic is impact our future workforce and how they are trained and how they're trained in other sectors, understanding the language, getting involved in understanding that, it's not just about giving care in one site, but it's really about understanding the full complex of needs that wherever that client is. And so for me, I think, hugely, it's about our next generation of providers and community, caregivers that will be, most profound to change this.
Allison?
For me, in addition to what Becky just described, was changing our workforce and changing how we provided care in the public health services. We added SBIRT, this screening, brief intervention, referral to treatment, to our regular services that we provide our clients that come in for other types of care. And it was initially a struggle because staff felt, oh, it's one more thing, it's just going to take up more time or whatever. And it's a challenge to screen somebody when you really had nowhere, particularly for uninsured people, to refer them. And that's what's in part the beauty of the program beyond the adult detention center. It also served our uninsured clients. It also allowed us to offer adult detention center released clients other communicable disease screenings, interventions. But most importantly, once our staff understood and got educated about substance use disorder, our clinicians, our nurses, even our admin people, because when somebody comes in, they're the first face that they see, the clients see, and their attitude can impact someone's comfort in getting care. So once we all realized the impact we were making through seeing these folks get care, getting into care, being able to get into care, our staff, it just changed their thought process. It allowed us to change our services. And we even celebrated after a year what we'd accomplished through the adding an SBIRT program into our normal services.
Great. So I'd like to talk a bit about the key components of this partnership. What do you each think are the key components that has led you to have the impact that you've had? And what are you most proud of? Major Lambert, I'll start with you.
So I think from the adult detention center lens, the key component was really about education. If we did not have the support of our partners, Dr. Sutter, Dr. Ansher, I would not have been able to do what I was able to do. I didn't know enough about substance use disorder. I learned an awful lot during this process and took every opportunity to learn more. And I think that in and of itself, the collaboration piece, the constant in contact, being able to pick up the phone, texting at 9 o'clock at night, providing the connections, at midnight, getting inmates sent here where another jail did not have medication assisted treatment so that we could provide the continuity of care. But I think that the whole thing here is really about the collaboration. It is about working together for a strategic purpose. In our case, it was constantly, how do we reduce opioid deaths? How do we reduce overdoses? How do we get these folks connected to services? And we were constantly asking each other questions. For me, to allow them to have the access that they needed to accomplish the clinical side of things was really my only role. It was just giving them access, working together to implement these types of, cursory type questions that would lead us down yet another rabbit hole in determining that there may be other things going on. So it really wasn't the focus just on substance use disorder. Other things reared its ugly head, and we had to kind of put other systems in place to support that. I'm a firm believer that if you're collecting information, you have to do something with it. And it was not uncommon to realize that we were dealing with somebody with a co-occurring disorder, and the mental health piece took precedence. So I would lean on Dr. Ansher, Dr. Sutter for guidance, and then we would pull in our medical team, our mental health team, and then develop a plan. It's a lot of work. It's a lot of work, but if we're saving just one life, I'm all in, right? And that is kind of the attitude that our staff has taken on. But the collaboration is the key. Developing those relationships, breaking down silos, trying to learn each other's languages, which is pretty challenging, but that's the key.
Thank you. Allison?
I'm going to say also being willing to be creative and accept if something doesn't work, you can quickly pivot and accept that you need to do something different. COVID, originally we were going to be in person, and then COVID happened, and all over the state of Virginia, including the district, care for substance use was even less than we already have in the community. But George Mason was able to pivot and start an incredible telehealth process to keep the individuals or the clients engaged and continuing to take their medication-assisted therapy. I also think because we have this unique collaboration between healthcare and the criminal justice system, the criminal justice system and first responders tend to be very well respected in the communities. And so having this collaboration, I believe the support of the criminal justice system allowed the community to be more accepting of what we're doing. When we first started, we couldn't find anywhere that we could put the mobile clinic except for out in front of the Prince William Health District. And I believe that the community would be much more open to and is much more accepting of what we're doing and understanding that a substance use disorder is a chronic illness.
Thank you. Becky?
I mean, I can echo just what Mandy or Dr. Major Lambert and Dr. Ansher said. You know, it's about the relationship, and it's about the ability to actually identify and rapidly shift to improve the processes that we've been developing. I think, you know, from the beginning, I said, and I've heard it throughout this, everyone's answers, there really has to be a culture shift in acceptance of having this work happen at all of our levels, both with academics and the way that we train and how we actually bring it into our curriculum, to the jail staff with Mandy, to Dr. Ansher and her staff. It all took a lot of work. It all sounds like it, you know, it's so seamless, but this took a lot of thoughtful conversations and education, because, you know, a siloed, isolated impact now has to become collaborative impact, where we're systematically kind of maneuvering things, and so we're all working in the right direction and all willing to make changes where they need to get changed. That took a lot of trust and a lot of faith from everybody, saying that, you know, can we implement this brief screen, or what we call the PNR? You know, can we implement that? And is Mandy's staff going to be open to that? So I think it really had a lot of infrastructural that was built around it to get us to where we are today.
Great. So as you know, we have people from all different sectors on this call. What advice would you give them about collaborating to change systems? What lessons have you learned? Not just the clinical ones or the ones with regard to jails, but what lessons have you learned about system change and collaboration that other sectors can take advantage of? Mandy?
So we were pretty fortunate here in Prince William County to have received some technical assistance from the National Institute of Corrections on evidence-based decision making. Had it not been for that technical assistance, I don't know where we would be today, but it really did give us an opportunity to share successes, but also air dirty laundry, right? There's no one system piece that's perfect. So we were able to really study the criminal justice system in Prince William County, cities of Manassas and Manassas Park, and really look at where our gaps were. And then we learned exactly how complex the Commonwealth of Virginia criminal justice system overall is. So we had a great opportunity to also work with the state at the state level to hopefully get some things changed that were prohibitive. So for us, it really was about already having a collaborative partner relationship in place with a charter. This was real hard work. Fortunately for me, fortunately or unfortunately, I was a co-coordinator with our pretrial criminal justice director. And even there, Pat, learning that role, that different side, I can remember vividly, he's saying when we were sending something out to the team, he said, I'm really proud of you. You're not talking like a jail person. So it really was learning other language, understanding that everything's not about safety and security, that there's so much more to the criminal justice system. The human piece of it, the human services piece of it, is really what drove a lot of this home for all of us that were kind of from the criminal justice lens. So having Dr. Ansher there to kind of help us mediate or really understand it from her thought process or her expertise really kind of brought it to a nice tied bow, in that we had all of the bases covered. It really wasn't just about the criminal justice system. We were able to absolutely see the impacts that the criminal justice system has on health services, right? We're doing our part in the jail. We're keeping people well. We're doing continuity of care. We're doing our reentry, but are we really digging in deep? And we weren't. So having the support again and having those policy team meetings where we really could just get on and say, hey, this is not working. A lot of really good work got done through system mapping, just having conversations. So for me, it really is all the stars aligned. We got accepted into the EBDM technical assistance and we kept it going. Sustainability is now what we're talking about. So making sure that as people change and cultures shift and paradigms happen, how do we sustain the hard work and successful work that has gotten us to today?
Thank you. Becky?
No, I agree that I think it's existing structures that you need to come into a community and say, where can we actually intervene instead of starting anew? First of all, you want to make sure you're building upon the work that is already existing, and then figure out how you can actually, intervene. I remember when I went to my first evidence-based decision-making team, and we were talking about medication-assisted treatment and peers, and it was foreign to everyone. It took a lot of time to kind of get all that moving along. So I think one is existing structures. The other thing is to ensure that anything that you're doing at a system level is going to impact the right people at the right place, at the right time, as it relates to, is there a voice of those that we're serving in this? That's where our peer recovery specialist work has just been so essential. They give us a regular check, right, Major Lambert? I mean, and Dr. Ansher, they let us know if we're off base. And so it really has been important, not just for them being part of our team, but really to be part of the voice of what the programming needs to look like in the communities.
Allison?
I think also making sure the community knows your successes, because without letting them know the positive things that have come out of this program, you really can't change the mentality or the thought of the community of what they're willing to accept. And sort of, I think that it was having the collaboration where we did see gaps. It wasn't pointing fingers. It wasn't saying, well, gee, this is your fault, what have you. Again, getting a better understanding of the reasons that the different agencies do things the way they do, and building upon that. It might have been easy just to go in and say, what do you mean you won't do medication-assisted therapy? It's just a medication like other medications that you're giving for chronic disease, but not understanding not only the acceptance or lack of acceptance of something of that magnitude in the adult detention center, but also accepting how their processes have to change. I mean, you all have the same goal. And understanding that you all have the same goal, and trying, I've seen other collaborations fail when, instead of trying to reach the same goal, each agency kind of has their own spin on what's important to them. But I think this collaboration, we all have the same goal, and that's saving the lives of those in our community with a substance use disorder, from the adult detention center and helping them be successful once they're out in the community. And that it does take hard work, and it does take not only systems change, but also workforce change, as Dr. Sutter had pointed out. I guess that's how I see it.
Thank you. So we're going to open it up for questions. I encourage those on the webinar to put their questions in the Q&A box. But before we go to those questions, do you have any last words that you'd like to share? Major Lambert.
So from my lens, from where I sit today, I would encourage every jail professional that's on the call to really give thought to what we've talked about here today. It is, oftentimes jails work very much behind walls. We usually get beat up when something bad happens in the jail. And it's simply not fair. For the most part, jails are doing extraordinary work and doing really good things to help people that have, had challenges. We have never been ones to judge people. We have a specific role, and that is maintaining safety and security. But I think our role has expanded. And I think that's what we need to start talking about, right? So we're always looking at ways to reduce costs and reduce recidivism and reduce in custody harm. One of the best things that you can do is develop a policy team that's outfitted by your judges, your health services staff, your prosecutors, defense attorneys, consumers, right? Those people that have lived it, and really get the collaboration piece going. There's some amazing support documents at the National Institute of Corrections website that would help you develop a collaborative team to just get started. We have obviously expanded from that. And I know that Dr. Sutter, Dr. Ancher is probably going to be publishing the hows and, you know, how to accomplish something of this magnitude. But from my lens, the best thing you can do for your organization is to get a collaborative team started where you meet regularly and really talk about the system as a whole.
Thank you. Becky?
Right. So I agree. You know, anything, you know, with the other thing I would add to what Mandy said is that, you know, dropping extensive barriers that we have to the navigation out of systems, I think is really important. And I think shifting us from an isolated impact to more of that collective impact, it's not just about the collaborations. It really does take that systematic approach that in our case, the evidence-based decision-making team in Prince William County gave us to really help us, you know, kind of align that and give that infrastructure that was needed. You know, it goes back to the relationships between the organization, getting towards that shared objectives. You know, I think that no matter how passionate, intense, and, you know, sometimes even exhausting this work can be, without us collaborating more in these cross-sector spaces, we're just never going to address the scale of what exists for our communities.
Allison, final words?
Yeah, I just think that now's the opportunity for folks to engage with public health, because public health 3.0 is the whole basis of it is this cross-sector collaboration. So this is the time and the opportunity for other communities to partner with their public health system, who I'm sure would be open to it. Many other communities have their own ways of addressing this issue, but I'm not sure how many have collaborated with their justice system to develop a program like this.
Great, thank you so much. So some of the questions that have been offered, can you tell us a little bit about how successes were measured? That is, what were the key indicators that were used, and how did you do that? What tools were used to determine that?
Major Lambert, do you
Becky,
want to
I'll
talk
start
about?
with you.
Oh, you want to start with me? So,
Yeah.
you know, we utilize, again, evidence-based decision making is kind of, they had some really great infrastructure in place as to some of the things that they were measuring, specific for the medication-assisted treatment bridging that we worked on. Those measures were about number of successes that have actually crossed that bridge, that have been able to actually engage with us in one, what we call an initiation visit, and then sustain with us greater than 3 months after release and connection has happened. So it's the number for us. It's also around the workforce training and how many students that we've been able to be exposed to this work. That was really important to us in our spaces. We monitor all the processes from a process evaluation perspective as it relates to the work that we've created collaboratively with Major Lambert in the Adult Detention Center. The pre-screener, we definitely monitor how many people have been identified, whether or not we need to do some changes to that over time. And so, you know, we've also expanded, you know, beyond just the original team that was working on this to include our other community partners. Most notably, our Community Service Board in Prince William is now actively involved in us figuring out how to leverage all of our resources and what makes most sense for who to do what. That I think, you know, they have, you know, also from that process evaluation been part of the conversation. But I would also toss that to Major Lambert, who has done significant work with the evidence-based decision-making metrics.
So when we first started the EBDM, we were looking at what data is important and what do we need to collect. And that is a moving target. It is so fluid. So we really were looking at pre-COVID, we were looking at jail population, types of people that we had incarcerated. It was more towards the criminal justice piece. With COVID, we found that we were collecting more information around the health services piece, right? Where have you been? Who have you been exposed to? So we were able to stop and pivot, but most of the data that we are collecting from a system-wide is really about average length of stay, what types of people do we have in jail. And one of the things that I will tell you all is that we were able to narrow down the number of inmates that were sitting in our facility and tie them to substance use, not necessarily opiates, but high percentage of them were, but tie the crime specifically with interviewing the particular inmates. And we were at 98% of our inmate population were in jail either for intent to distribute or drug-related charges, or charges that are associated with being an addict. For instance, burglary, breaking and entering, prostitution. So we really looked hard and fast at those numbers and realized that we needed to do a little bit more. So we actually joined a grant to give us a little bit more technical assistance, NIATEX with University of Wisconsin and George Mason, to help us expand medication-assisted treatment in our jail. But data tells a story, and jail folks aren't ordinarily looking at data. But data to me has become kind of what I've hung my hat on. Every morning I will come in and look at how many failure to peers do we have sitting in jail, how many people that came in last night with drug-related charges, and then we start talking about those things. What has happened though, Pat, is based on the PNR that Becky referred to, which is our initial pre-assessment, that when they walk into booking, we're administering those questions. We can tell the repeat offenders, we can tell who's at the highest risk of overdose, we can tell who is prescribed Suboxone, and then who is not. And let me just tell you, don't stop. So we had people that were coming in that were indicating that they were on Suboxone, but refused to continue taking it in jail. And when we started digging, what we found out was they were refusing to take Suboxone because they weren't allowed to be in a trustee or a worker position while they were on Suboxone in the jail. My question was why. So we worked through that, navigated through that, then allowed them to continue, to be able to work, and we were able to sustain more folks to maintain them on their medication. So it's constantly a moving target, but the data tells a story, and that's how we started kind of uncovering what was going on with people being resistant to taking or continuing on Suboxone. So any data that you could possibly collect that tells the story of what's going on in your facility in terms of the health piece of it is really what we're focusing on today. Tomorrow that could change, but data is critically important.
So I want to bring it back to the question of systems change. How are you measuring or tracking systems change in this work?
I'll take that. I think it's a great question. I think that part of it is the number of process changes that are being brought together from different lenses. I think that's the work that we've done in implementation and changing policy, like Major Lambert just talked about. That's huge. I mean, that just is not something I think that would happen without really looking at the systems and utilizing the data that we've been able to get from a health perspective, which is not traditional criminal justice, data that would be looked at and evaluated. And certainly, I don't think, Mandy, you can correct, or Major Lambert, correct me if I'm wrong, is that wouldn't be part of the conversation. Previously, if we weren't doing our pre-assessments and identifying those linkages that potentially could change. So I think, again, it's taken time for us to get to real system policy change through the culture shifting, through the education, and through all of that. But, that's, I think, something, how many policy changes have been made? How many times are we, in evidence-based decision-making, coming together to really talk about, the non-traditional criminal justice things?
Allison?
Yeah, it's also caused system changes outside the adult detention center and in the community. not surprising, we recognize a lot of these folks might be positive for hepatitis C. George Mason initially connected with the University of Virginia for being able to provide care for these people who tested positive for hepatitis C, which can be expensive. And now George Mason in our community is a center for hepatitis C care in Northern Virginia. And that's something that we didn't have before. People used to have to go down to UVA for treatment, which was certainly a barrier to access of care. So from a health perspective, it also changed systems outside of our initial intent.
Thank you. I had a question. Do you have any examples of linking a newly released client to a community clinic?
But do you want to take it and then toss it to me from the bridge side of it, of how we identify and get?
Sure. So what we typically, well, one of the examples I can give was most recently we had a reach out from George Mason that had a client that they had on medication assisted treatment that was going to serve some time in another facility. I reached out to that facility to determine whether or not they offered MAT. I was told no, they do not offer MAT. So we knew right then and there, if we did not do something, that he would be discontinued from MAT. So I offered to house him here and maintain him on his Suboxone while he was incarcerated with us. We had a lot of paperwork shuffling, orders that had to be shared, arrival times because he was a late report. It took a lot of navigation and logistics to get everybody on board, to include our medical staff. And it worked. He stayed here, he maintained on his Suboxone, but if it had not been for the reach out from George Mason or that person that was getting ready to serve jail time saying, I'm going to jail and I don't think I'm going to be able to continue my Suboxone. Had it not been for the trust that had occurred between George Mason and partners with that particular client, he would have probably been a statistic, in my opinion, based on my knowledge of this particular case. So we were able to navigate him back to our facility where we knew that we could continue him on Suboxone. That's just one example. There are many more, but I'm going to let Becky talk a little bit about how that all happened.
Right. And so, when they identify and when he had actually come to us from the Prince William Adult Detention Center, we had standardized care with him and then he was going to be reincarcerated. So that was a prime example of really a continuation of care that is just the absolute ideal, but just from a clinical perspective, that's an absolute ideal, that there's no gap in any of his care, both in jail and then returning back into the community. For our new ones that we are identifying in the booking space, or what through our PNR, our pre-assessment, they are really rapidly connected to a peer recovery specialist, especially if we consider those the ones that are going to be rapidly released back into the community and potentially not have time for a whole lot of programming or a whole lot of planning needs. They're connected very quickly to a peer recovery specialist who then will be able to connect and come up with a plan, and once released, be able to within 12 to 24 hours receive what we call a bridge appointment, which means that if they are new and will be new onto Suboxone, we're able to actually engage them very quickly with the peer, which is so key to maintaining engagement and trust. They trust the peer, therefore they trust us, through this initial care. We're able to actually kind of engage them, start them, and then get them seen quickly and started on the medication that we know is just simply evidence-based best practice. So we've really created this very seamless, but it's the processes, it's the systematic way that we do things. It's from early identification to the intervention that our peers can do. So that has really been successful for so many.
Talked about the challenges of collaboration in each of your organizations, but you also have other groups involved in your work. How did you get them engaged? How did you motivate them? to be collaborators? What were the challenges of that work?
I can take this one. So I think we dangled the carrot, right? So what's in it for you? And how can we make our system better? What is it going to take? And it really does involve everyone, right? When we started developing the list, first of all, we didn't realize how many characters came into play. And our team was rather large. We probably had about 40 people on our evidence-based decision making, but I'll tell you, with the right facilitator, it was effective. So the motivation really was us dangling a carrot. Like, really, what can we do to show that we are doing the right thing for our community? We used language such as, these are community members, so we should really be invested in their successes. They don't hear that from people that wear a badge oftentimes. We don't talk about stuff like that. We just do it behind the walls. So to be able to verbally say, wearing a badge, we need to invest in our community members, those folks that are incarcerated in our jail, because at some point they're getting out and they're coming back to our community and we want them to be successful. So those are the types of languages that we use to keep people motivated. And I will say also that the group of people that we had on our team were caring people. They care about people. Oftentimes you're not going to get into this business, public safety, health, if you don't genuinely care about people. I think the problem is we don't talk about it. For instance, here in Prince William County, I don't know that you've ever seen a press release about the stuff that we're doing. We just do it. And we do it and we're able to show that we've been able to reduce recidivism. Our overdose death rates are not because of people coming out of the jail anymore. We're able to really put some data behind what we're doing. Shooting from the cuff, there's an awful lot of data out there, but we're able to show that we let 5 people out and in 2 years, they still haven't come back. And those are all the ones that were connected with Dr. Sutter and Dr. Ansher. So we're able to connect the dots, but motivation, it really does take a village to keep people motivated and engaged. And as somebody changes, and that happens frequently in our business, we make sure that there is going to be sustainability within that particular area. Again, Pat, I can't tell you, in all of my years of being in this role, this has been probably the most challenging and the most work I've ever done in my capacity. But it has paid off. Well worth it. Well worth it.
Thanks. There's a question that actually is probably for me. How do you break down the silos and work collaboratively when there's little incentive for outside funders to do so? I think one of the things that those of us in philanthropy understand more now than ever before is that one sector can't fix all the problems. So funders are increasingly looking for meaningful collaboration. And I believe it's not so much breaking down silos, but connecting silos. Major Lambert's point of what's in it for me is a way in which to get folks to understand that we all have skin in the game, and therefore making that case to funders can be really strong. So I wouldn't assume that there's no outside funding for collaborative work. We're seeing quite the opposite of that. The last question I think I would like to direct to Allison. The issue of public health is one that you've raised on several occasions in this conversation. What is the lesson that you've learned from this work?
As public health professionals, we tended to try and do everything, solve everything ourselves without reaching out to our other partners. The Affordable Care Act required us to do a community health assessment and a community health improvement plan. And I think that helped us realize that public health can't and will not be able to do everything themselves and be successful and maintain their services, that we needed these cross-section collaborations to be successful in what the community wanted us to do to improve the health of the community. And so I have to give credit to the Affordable Care Act, encouraging us to do this community health improvement plan that forced us to look at what partners outside public health can make us successful. And actually, our most recent community health improvement plan, we've educated our community and we're very proud of our community. They understand other things that impact health. And right now, one of the things we're working on is the connection between housing and health. And that's something that would have never happened before. So we have planning working with us on housing and health. We have also a organization that did a study of our community as to the housing and health, something that they've never done before. They've always looked at housing in respect to just cost, but now they can connect cost to health. And so I just think that as we move forward in public health, as I mentioned, we're moving into public health 3.0. These cross-sector collaborations are so important to make public health successful. After all, I think everybody has heard out ad nauseum with the COVID response, how the public health infrastructure has really been, it's been shown that we do not have an adequate infrastructure to do everything ourselves. And so that is one of the positive things that has come out of COVID, where now elected officials recognize the importance also of this cross-sector partnerships to get things done.
Thank you. With that, I'd like to thank our speakers for joining us today and our viewers for tuning in. To learn more about this issue, you can check out the Northern Virginia Health Foundation website. We will also provide each of you on the call with contact information for our speakers, because I'm sure you have some specific issues that you would like them to address. Thank you so much and have a great day.